the previous speakers' talks and this discussion, I think we're all going to end up in violent disagreement, or rather violent agreement here. I was asked to cover the topic of clinical and biological phenotypes of ARDS. What do they have in common? And I think this is, whoever put this session together, it's very nicely sequenced actually to come after the previous two talks. These are my disclosures, which are not especially relevant to what I'm going to talk about today. All right, so as the previous speakers have very nicely outlined, ARDS we know is a heterogeneous syndrome. I even have ARDS in quotes here because we know that it encapsulates many different specific diagnoses. And even since that original definition in 1967, we've been thinking about whether we should be splitting ARDS into groups based on clinically obvious features, direct versus indirect lung injury we've talked about, COVID-19 versus typical ARDS, sepsis versus non-sepsis, and we could probably all come up with at least 10 or 15 more ways to split this. At the same time, particularly over the past couple of decades, we've been thinking more about other ways to split ARDS based on biology, and we've talked about some of those already today. So reactive versus uninflamed, hyper versus hypoinflammatory, epithelial high versus low. And so the question that I'm going to focus on today is, what do these different approaches have in common, and is there a way we can synthesize them together? So let's start from the viewpoint of clinical phenotypes, because that's what's obvious to us as clinicians at the bedside. Are clinically obvious phenotypes biologically distinct? And I'm just going to show a few examples. This is not meant to be all-encompassing, but I'll start with one that compared trauma versus non-trauma ARDS, and this was actually a paper that we published about 15 years ago in Critical Care Medicine, in which we studied almost 1,500 patients from the ARMA and alveoli trial and compared patients with trauma as their etiology to patients with all other etiologies. And there were many different clinical differences between these groups, but importantly, there were also some really interesting biological differences. So you can see here that ICAM1, SPD, von Willebrand factor, soluble TNF receptor 1 were all significantly lower in plasma from patients with trauma-associated ARDS compared to non-trauma-associated ARDS. So this was suggesting that, yes, this clinical phenotype we can see pretty obviously at the bedside is also reflected in differences in lung endothelial and epithelial injury and perhaps some differences in inflammation. Similarly, and the previous speaker referred to this study already, so I won't go into it in too much detail, direct versus indirect, again, a clinically obvious difference to us at the bedside most of the time, I'd say. Patients with pneumonia and aspiration versus patients with non-pulmonary sepsis, we can observe that difference, and there are also biological differences between these patients. So in both single-center and multi-center studies, we found that patients with a direct etiology of ARDS had higher levels of plasma epithelial biomarkers like surfactant protein D and RAGE. And these patients had relatively lower levels of biomarkers of inflammation and endothelial injury. Let's take a different biomarker, and again, this is one that the previous speaker mentioned, soluble RAGE, or receptor for advanced glycation end products, which we think is associated with alveolar type 1 epithelial injury. So the group from Jean-Michel Constantin and Mathieu Joubardon has studied this extensively as part of their interest in diffuse versus focal ARDS. And as you can see from the figure on the right-hand side, patients with non-focal ARDS have higher levels of this biomarker of alveolar epithelial injury, showing us again that this, clinically evident distinction has a biological component. However, though this data really supports, I think, biological heterogeneity by clinical phenotype, these biomarkers are not different enough to serve as surrogates for clinical phenotype. And this, again, is exactly what Dr. Pellegrini was getting at. There's a ton of overlap here, for example, between direct and indirect lung injury in these different biomarkers, though they may be statistically different. So what if we take it from the other perspective? What if we say, okay, let's look at biologic phenotypes. So phenotypes that are identified just on the basis of biology, can we identify clinical distinctions between those? And here again, I'm going to refer to a paper by Lou Abbas that was shown in the prior talk, in which he and his colleagues in the MARS consortium took about 15 different plasma biomarkers and just used those alone to say, can we identify discrete subgroups in this heterogeneous group of patients we call ARDS? And they found two subgroups which they termed reactive and uninflamed. And there were several clinical differences between the two, including the prevalence of chronic lung disease, direct versus indirect source, SOFA scores, and most importantly, clinical outcomes. Interestingly, these ARDS phenotypes, defined entirely by plasma biomarkers, are also identifiable in mechanically ventilated patients without ARDS. So this is a really important paper, I think, also from Dr. Buss's group, published in the Blue Journal last year, that showed that even in mechanically ventilated patients who do not meet ARDS criteria, patients who fell into the reactive phenotype, that was the more inflamed phenotype, had higher Apache and SOFA scores, had lower compliance, and had worse outcomes. So I think this is really getting back to Giacomo's point earlier that, that there are implications of this that go beyond just our syndromic definition of ARDS. These biological phenotypes seem to extend past our traditional definitions, and I'd query, do they even extend past patients with respiratory failure to sepsis and other critical illness syndromes as well? All right, so let's take a slightly different approach and say, okay, now what if we look for distinct phenotypes within the data? Are those phenotypes really defined more by clinical or biological characteristics? So if we let the data teach us, okay, what are the actual phenotypes that emerge just from the, looking at patterns in the data, what do we see? And so our group has used this approach that's been referred to a bit already today of latent class analysis to ask whether we can identify distinct data-driven phenotypes. And this hyperinflammatory phenotype that we've identified seems to have higher plasma levels of inflammatory biomarkers, consistently worse outcomes, and in secondary analyses of RCTs, they appear to respond differently, these two phenotypes, to high versus low PEEP, to conservative versus liberal fluids management, and to simvastatin for pharmacotherapy. But are these really biological phenotypes? Actually, they're really kind of a hybrid of clinical and biological data. So let me show you what I mean. So this is a figure that I think Giacomo showed earlier. On the x-axis are the continuous variables that were used to define these latent phenotypes. And yes, the biomarkers at the extremes of the figure, which are those that really distinguish the phenotypes, most predominantly, are dominated by biological markers like protein C, interleukin 6, and interleukin 8. But these are all the clinical variables in this model. So in fact, there's a ton of clinical data in the model in addition to demographics like ARDS risk factor. So really both clinical and biological data are contributing to the identification of these distinct data-driven phenotypes. In fact, it turns out that you can use just the clinical data alone from these phenotypes to identify them using a machine learning model. And so this is work that was done by Pratik Sinha, who's a junior faculty member at Washington University, and Matt Cherpek, who's at University of Wisconsin, in which we applied a machine learning technique called XGBoost, which is kind of like a variant of random forest, to all the clinical data that you see on the left-hand side of the screen, which were the clinical variables that went into the latent class model. And so using this algorithm, we could achieve pretty good areas under the curve for identifying these phenotypes, 0.94 to 0.95 in clinical trial data sets and 0.88 to 0.92 in observational data sets. In fact, in collaboration with Giacomo and John here, we applied a variant of this clinical classifier model to data from the LungSafe study. And I just want to highlight that this was work led by current pulmonary fellow at Stanford who did this work when he was an internal medicine resident with us at UCSF, Manoj Madali, in the lower picture. And what we found was in the LungSafe cohort, which I think you're all familiar with, patients allocated to the hyperinflammatory phenotype by this model had dramatically worse survival. And in quite a surprise to us, we seemed to observe a similar pattern of response to PEEP as what we had observed in the alveoli trial. Now, big caveats here in that PEEP allocation, obviously in the LungSafe cohort, which was observational, was not random, right? It was, assigned by the clinicians. And so you have to take it with a big grain of salt. And also we omitted the middle PEEP tertile. We were just comparing the highest to the lowest. But nevertheless, we seemed to see this difference in treatment response that goes back to the last question we had in the prior talk, which is really, why do we care about all these phenotypes, right? We care, I think, because we're seeking groups that respond differently to treatment, because we want to be able to better target our therapies. All right, well, let's talk about another clinical phenotype, and that's COVID-19, which we've had endless debates probably at international critical care meetings over the past 2 years over whether this is a different phenotype of ARDS or not. And so in collaboration, again, with Dr. Sinha, as well as with Dave Furfaro, Max O'Donnell, and Dan Brody from Columbia, we asked whether or not we could identify distinct phenotypes, data-driven phenotypes in COVID ARDS using the same approaches, and whether or not these phenotypes would overlap with those phenotypes I've been telling you about. We studied almost 500 patients that were enrolled in just 2 months at a single medical center in the first wave of COVID, which I think can give you some sense of the incredible strain that they were under at the time. And we used both that clinical data-only classifier model that I showed you, as well as applied a de novo latent class analysis to identify novel phenotypes. In fact, that latent class analysis did identify 2 phenotypes as being the best fit for the data, and I'm showing you here the same type of diagram I showed you earlier, with the continuous variables used to identify the phenotypes on the x-axis and the standardized value of the variables here on the y-axis. Now, these are slightly different variables than we had used in our prior studies because we had very limited biological data. So if you look at these data points, really only one of them, IL-6, is what we'd typically think of as like a research biomarker, though several others of them are inflammatory biomarkers that are commonly used, that were commonly used rather in the early days of COVID, lactate, troponin, procalcitonin, and interestingly, CT there is cycle threshold, which we all know is sort of a surrogate for viral load. It did not contribute at all to distinguishing these phenotypes. Okay, well, are these the same phenotypes as the hyper and hypoinflammatory phenotypes? This is a Sankey plot that shows the overlap between the COVID ARDS bespoke phenotypes and the previously described phenotypes on the left-hand side, and you can see that there is some movement between these two groups, but there's quite a bit of overlap, suggesting that they may be, in fact, quite similar. Regardless of which of these 2 approaches you used, they were both associated with major differences in survival. So you can see the COVID phenotypes on the left, the hypo and hyperinflammatory phenotypes on the right, both highly statistically significant. But perhaps of more interest is that both of these phenotyping schemes appeared to pick out groups that responded differently to corticosteroids. Now, again, I want to issue a big caveat here that corticosteroids were not randomly allocated, but this data was all collected before recovery came out in June 2020. So about 2/3 of the patients got corticosteroids, and those patients were evenly distributed between the hypo and hyperinflammatory phenotypes and between the 2 phenotypes that we derived that were unique to COVID-19. And what you can see here is that if you were in the hyperinflammatory phenotype or the more inflammatory class 2 COVID phenotype, you appeared to have a survival benefit from corticosteroids, whereas the opposite pattern was observed for the corresponding other phenotype. So this is nothing more than hypothesis generating because it's retrospective. But again, it gets back to this idea that we're searching for treatment responsive subgroups here. And it may be that those responsive subgroups are best defined by a mix of clinical and biological criteria. All right, to summarize, there's really actually quite a high degree of overlap between clinical and biological phenotypes. And I only mentioned a few examples here of clinical phenotypes, but each of these has, important biological heterogeneity that they're reflecting. And likewise, conversely, phenotypes identified by biology alone have different clinical characteristics. Latent class models are just one of a number of different types of approaches that can combine clinical and biological data. And so I think one of the things we've been talking around in this session so far today is one approach better than the other, right? Is it better to use clinical data? Is it better to use biological data? Is it better to use a combination? Well, I think it really depends on the question you're asking. And this actually, Giacomo and I did not synchronize our slides ahead of time, but it really gets back to the point that he was making at the end. I think it really depends on what question you're asking. And again, the prescient question that the last member of the audience asked, why do we care? I think we care because we're seeking differential treatment response. And the best approach likely depends on the treatment being tested. And I just want to present one possible vision of how this might emerge in the future. And this is taken from a perspective led by David Maslow and John Marshall that I contributed to, as well as many other people, that was published a couple of months ago in Nature Medicine on the concept of redefining critical illness. And the idea, sort of the vision for the future that's laid out here, is that at some point we may have phenotypes that are derived from a combination of clinical, biological, physiological, imaging, and multi-omic parameters that we're able to integrate into distinct groups that we could call treatable traits, we could call them endophenotypes. But again, getting back to this idea that our ultimate goal is to find groups that respond differently to therapy. Thanks very much, and I would be happy to take questions.
Wow, that was amazing.
Oh, thanks.
Questions from the floor? Yes, I think it's Dr. Bauer.
Yeah, Philip Bauer from Rochester. I mean, nice talk. I've always been intrigued. ARDS has many reasons, many causes. I can think about smoke inhalation having many, many causes. And COVID is one of the most fascinating stories because, COVID is a infectious pulmonary disease. And at the beginning, when you described the series that you have, there was no antiviral agent, there was no immunization. So it seems to me that I would be curious to know if you have studied, or if you are probably studying the phenotype that you describe after first vaccination, and next after early antiviral agent, because remdesivir and stuff, monoclonal antibody, were given too late. But now we know that remdesivir, for example, or Paxlovid, or those given early kind of blunt the response, although some still develop ARDS. So do you think the phenotype will change with the treatment of the cause of the ARDS?
That is a wonderful question. So I'll give you a couple of thoughts in response. One is that I think we really need to study the trajectory of these phenotypes over time within an individual patient. So I didn't show this data. We've reported that these phenotypes appear relatively stable over the first 3 days of disease in the ARMA and alveoli trials, but that was 20, 25 years ago. And how are these phenotypes modulated by therapies is really unknown, and can that modulation be actually a therapeutic target is also unknown. To get more specifically to your question around COVID and how it's changed over time, so we do have some very recently analyzed data that we haven't published yet, but Nargis Alapana-Lechner, who is a postdoctoral fellow in my group, has been analyzing data that we have on patients enrolled in the ICE by COVID trial, which is a phase 2 platform trial conducted at 30 plus hospitals around the US. And all of the patients were treated with corticosteroids, and they were enrolled in later time points in the pandemic. And we see a very different pattern than we saw in this early phase of COVID. Now, whether that is related to variants, vaccination as you raise, corticosteroid treatment, right? Because the data I showed you from Colombia, that was all data from within the first 24 hours of intubation, right? So very, very early on in the course, probably before steroids were even started in many cases. So what has caused that pattern to change over time, I don't know, but I have a strong suspicion that, for example, steroids, IL-6 receptor blockade, et cetera, are almost certain to modulate some of these pathways and therefore change the patterns we see.